yourself and ask a question. Happy to entertain in both formats. There also hopefully will be some time at the end for questions and discussion. So I'd also like to acknowledge before we get started the work that was done at UCSF regarding prognostication and the development of the e-prognosis tool that I'll be sharing at the end, which I think is very useful, and hopefully you'll find it so as well. So our objectives today, if you're not familiar with the topic of prognostication, don't worry, by the end of this talk you will be. We'll talk about what it is, some of the benefits and barriers to prognostication, how to very quickly determine life expectancy in an older adult, and 3 methods of estimating prognosis. And if we have some time at the end, we'll talk about communication for prognosis. If not, we'll save that for another echo session. So prognostication is a 2-part process. It is the formulation of the patient's prognosis by the physician or clinician and the effective communication of that prognosis to the patient. And we tend to think of prognosis as it relates to very serious conditions. So cancer, conditions like dementia or ALS, Parkinson's disease. So in a very disease-focused way. But in the elderly, it can include an estimation of life expectancy and functional capacity. And doing this can greatly inform patient-centered goal setting and shared decision-making. So it really can inform our ability when we care for older adults about the need or excess of certain medical tests, screenings, and procedures. And if you think about it, we really do estimate prognosis all the time in very, in what I would consider like sort of very quick, everyday method. So if you see a patient, for example, who has a UTI and they're symptomatic, you tell the patient, I'm going to start you on antibiotics. This is what your urinalysis shows. And, after about 2 days of taking this medication, you should start to feel better. But if you don't, let me know. So we're sort of we're giving some prognostication there in terms of what we anticipate for that individual. Also, there's been a lot of work in the space of back pain. And we know that, for people that have no red flag symptoms, but mechanical low back pain, that, generally we tell the patient, within 6 weeks, you should start to feel better. If not, we'll get some, maybe then we'll get some x-rays. So you are giving the patient some information about their prognosis. And we do this really without even thinking about it. Now, there is, a lot of reason to want to give patients prognosis in a meaningful way. And in particular for our older adult population, it does help to delineate realistic goals of care and greatly inform care decisions. For patients that are approaching the end of their life, if you deem them to have a life expectancy less than 6 months, maybe it qualifies them for hospice care, can aid a patient and family for decision-making for the future. I think in general, patients appreciate this, the honesty and even the uncertainty that a clinician might face. And then, for patients, I think it's helpful to be goal-oriented and patient-centered and really understand what is meaningful to them. And it can foster that discussion, particularly around functional recovery, independence, and maybe even meeting a milestone to attend a child's wedding or go to a baseball game or something of that nature. There was a landmark study looking at community dwelling older adults, and they were asked about their preferences for receiving CPR, in fact. And after learning about the probability of survival following hospital discharge, after having received CPR, so after having received this information about their particular prognosis, the desire for CPR dropped from 41 to 22%. So I think this is really meaningful information that can help guide a patient's future care. Now, as clinicians, if you're like me, when I was in medical school and even in residency training, I did not get a lot of information about how to have this discussion or even where to find information about determining life expectancy or how that might interplay with the tests. and offerings that I was discussing with patients. And so, I think there's a reluctance on the part of the clinician to maybe engage in this conversation. And there's also this concern that we don't want to take hope away from patients. And certainly I've seen that culturally as well. So we might feel that if we have this kind of conversation about life expectancy, that we might take away one's will to live, so to speak. But evidence does suggest that discussions about prognosis do not negatively impact hope or overall ability to cope with illness. And patients and families often want to discuss prognosis to get help with planning and decision-making, of course. And our patients are really looking to us to have these difficult conversations. So we want to be equipped to do so in a meaningful way. So before we get into the details of the talk, let's start off with a case. This is actually a case that Valerie, George, and I saw in clinic together a few years ago. And it was a woman, I'll just call her Miss AJ. She was a 90-year-old female who came to our clinic with her daughter, and she had the following medical history. So she had a mild degree of memory impairment, and she had well-controlled hypertension. And her parents and her siblings all lived to between 95 and 100 years of age. And in the course of the conversation, her daughter was requesting a mammogram. And so we were, really faced with this decision about, should we order a mammogram for this woman who's 90, or, do we have a conversation about foregoing breast cancer screening? What should we do? So we asked for more information from the patient. And in fact, she had no history of hormone replacement therapy use. She had no radiation to the chest. She had no family history of breast cancer in her siblings, grandparents, parents. Her daughter did have she did have a breast biopsy at the age of 68, which was benign. And her daughter was diagnosed with DCIS at the age of 50. So this was the presenting information as we had it. So question for you all, what would you do? So would you order a mammogram in this patient? Would you defer decision-making to the next visit? Because it's often hard to have this type of conversation when you're managing other chronic conditions. Maybe defer and then ask her to think about her request, or decline to order the mammogram. So think about that for a moment, and maybe put in the chat what you would do. So your options are to order that mammogram, defer decision-making, or decline to order. I can't actually, Nika, you're gonna have to, I can't see the chat, I'm sorry.
Yeah, sure. We have Dr. Tabarsi saying, I would recommend discussion of goals of care that fall under forums of age-friendly health systems. And then we have quite a few people saying to defer. We have somebody saying, I would educate the patient on benefits versus risk. And then if she wanted to proceed, I would order the mammogram. Somebody just mentioned order mammogram, suspect greater than 4 years of life expectancy. And that's what we have so far.
Wonderful. Thank you so much, Nika. So all great comments in the chat, and a difficult situation, right? So if you kind of dissect out your options here, right? Ordering the mammogram might be the easiest choice, right? It's a click of a button if you're on Epic like we are. The patient's daughter would be happy. This is her request. We do, clinical medicine today, we have satisfaction scores that sometimes are in the back of our mind in terms of, these surveys patients fill out. So maybe the daughter would be happy. It's probably the least time consuming. But, you got to wonder, is there evidence to suggest that the patient should, would they benefit from this? Or is there some potential harm from ordering the mammogram? And then if you decline to order the mammogram, how could you convince this daughter that not ordering it and not pursuing this workup is actually appropriate for the patient. So how do you factually and logically present this to the daughter? And I think in this case, it's particularly meaningful. The daughter was the dean of one of our local institutions of higher education. So she was very educated, very savvy, and really, would want to engage in that kind of discussion, particularly if we declined the order. So as we contemplate some of those questions in the previous slide, it's important to think about this concept of lag time to benefit. So, incorporating this concept of lag time to benefit is important, especially when we discuss decisions around diagnostic or therapeutic interventions when the benefit is not immediate. So, and it's really helpful when we're thinking about screening tests, for example, breast or colon cancer. So lag time to benefit is defined as the time between an intervention and when the improved health outcome might be expected. So determining the likelihood that a patient may live long enough to benefit from the intervention can actually help clinical decision-making. And I think someone in the chat actually said, maybe this lady actually has a life expectancy greater than 4 or 5 years. And in that case, maybe, a mammogram, it would be okay. So if a patient's life expectancy is significantly less than the lag time to benefit of a preventive intervention, the likelihood of that patient being harmed rather than benefiting is high, and you might consider recommending against rather than pursuing the intervention. But if a patient's life expectancy exceeds the lag time to benefit, then the likelihood of benefiting from intervention is much higher. So the way I think about this is, we now recommend screening patients who are 45 and older for colon cancer, right? They obviously have a life expectancy in general, greater than 10 years. So that makes sense. Whereas if someone who's 90 comes in and wants colonoscopy, maybe that's not necessarily, the most advantageous, and the risk there is significantly greater. And just one way to think about it. There are these tables that you can find online. This one's from JAMA. Prognostic indices for older adults, and it kind of talks about life expectancy and different tests. And you can see here that, for example, if someone had, when should you discontinue a statin? So they're saying here, if life expectancy is less than 6 months, obviously referral to hospice less than 6 months. Blood pressure, aiming to get a blood pressure less than 140/80. So life expectancy probably greater than a couple of years. So you can find tables that can inform you of this. And then there is also this table, I think this was put out by AGS, that looks specifically at lag time to benefit. And you can see here that, for SSRIs, it's about a 1 to 2 month lag time. For statins, it's about a 6-month lag time. Blood pressure, a couple of years. And then one I think that we're all familiar with is tight glycemic control for the prevention of microvascular complications. The lag time to benefit there is almost a decade, right? So 10 years, which is why for our oldest folks who, are certainly approaching 80 and 85 with diabetes, we relax on the A1C targets because the lag time to benefit there is so great that the individual might not live to see the benefit of the prevention, and there might be more risk of hypoglycemia. So I think someone touched, as I mentioned before in the chat, about life expectancy. So let's take a moment and think about life expectancy, right? So our patient's 90 years old. And, obviously life expectancy has changed due to COVID over the last few years. But in general, if we think about life expectancy, which country or region has the highest life expectancy and which has the lowest? So maybe put your ideas in the chat for me. And remember that life expectancy, is influenced by gender, genetics, access to healthcare, hygiene, diet, nutrition, exercise, lifestyle, crime.
Somebody just said Japan has the longest lifespan.
Very nice. So close. So this data, I actually pulled it a couple of years ago, but I checked last night, and it's from my source that I used yesterday. It didn't seem to be accurate. So highest life expectancy, Japan was number 2, Hong Kong number 1, Macau, Switzerland, Singapore, Italy, Spain, Australia, and Iceland. There, Channel Islands in the top 10. So, these are countries, obviously, they're very developed. They have, I was reading about Hong Kong last night. They put a lot of time and effort into their infrastructure, green spaces, and have a healthy lifestyle with lots of activity. And who has the lowest? So not surprisingly, here we have number 84 to 93, and these are primarily countries in Africa. So you might be wondering, and you probably all already know, so where is the United States in all of this? And this is what really matters for our patient who is 90. So in the United States, we are number 46, and our average life expectancy is almost 80 years of age, 79. I think this has decreased a little bit because of the pandemic, but in general, so we're hovering somewhere in the 70s. And our patient who is 90 has clearly exceeded the average female life expectancy for a United States female. So does this help inform us regarding her request for a mammogram? Right, so she's already outlived her what we would consider, the average life expectancy. So she's doing quite well, but I'm not sure that this is necessarily helping to guide me in one way or the other in regard to my conversation with her. So what other tools can we use? So as I mentioned before, general life expectancy data, it's helpful to a point, but we really want a more accurate, methodical way to prognosticate for older adults, especially since we know in geriatrics that no two 80-year-olds or no two 70-year-olds are alike. One might be running marathons and the other one may have succumbed functionally to chronic conditions and be in a wheelchair, or have other functional issues that impact quality of life. So to be more specific, or to get more specific, there are a few additional methods to consider. So one would be your clinical judgment. We all have experience in patient care, and we develop a sense of who we think will do well and not. There are additional life tables or life expectancy tables to look at. And then there are some indices, some calculators that are available as well. So let's transition now and talk a bit about these. So in regard to clinical judgment, with time and experience, we build a set of cases in our mind that shape our estimation of prognosis. And as clinicians, this has been looked at and studied. And I think this general sense is we tend to overestimate survival by a factor of between 3 and 5. We tend to be more accurate for short-term prognoses rather than long. And of course, our relationship with our patients and how long we've been in that relationship does factor in and can lead to some error there. So while our clinical skill is definitely important, we should recognize some of the limitations. Now, there are more accurate life tables that we can talk about that focus on not just life expectancy, but really kind of get down to the nitty-gritty of how healthy someone is and where they fall in comparison to their peers. So average life expectancy tables based on a current age provide a broad estimate of median survival in the general population. But just as we saw, our patient had outlived her expected, the expected life expectancy in the United States. So we really want to focus in on the general health of an individual. And you can see here that this is just a very simplistic life expectancy table looking at females in the United States, looking at age, and it can give you just an idea of where someone who's 80 or 90 years old might fall out. Now, a more specific life expectancy table is presented here, and it divides up patients based on quartile. And basically, this table acknowledges that there is a great variation of life expectancy for people of similar age based on their overall general health. And you can see on this table that ages on the x-axis and life expectancy on the y, and the green line represents the healthiest women in the United States, those in the top 25th percentile at each age. So these are active people with no significant comorbid illness. The blue line is the 50th percentile or average expectancy at each age, and the red is the lowest or 25th percentile at age. Sickest folks with severe comorbid illness like dementia, congestive heart failure, et cetera. And so I think it's important to know, if you have a general sense of how your patient is doing in comparison to peers, you could use a table like this. And it can be presented in this fashion here. So you can kind of see here that, for a 90-year-old individual, at the 50th percentile, their life expectancy might be 4.1 years. More for someone who's healthier, and a little bit less for the bottom quartile. Okay. I'll take a moment and talk about some prognostic indices. And examples are presented here. And in clinical practice, before, when I was an internist in training, I wasn't so familiar with these tools, but things that we used very routinely would be, like a MELD score or a CHADS BASC score that we use, even in geriatrics, to look at, prognosis and estimation of risk. So these tools do exist, and you can certainly take a look and see. They are fairly lengthy. They do have several questions, and it's important to understand each tool based on the setting in which it has been validated. So you want to use the correct tool for the correct patient. So for example, if you are using a tool that has been designed for a nursing home population, it wouldn't necessarily be appropriate for a community dwelling adult, as it might likely underestimate their prognosis. And additionally, so the tools that we use very clinically, they're very disease specific. So might focus on a particular malignancy or particular chronic condition. Whereas in geriatrics, our patients have a complex mix of medical comorbidities, functional issues, cognitive issues, et cetera. So we have to be careful when using a very disease specific index. So in clinical practice, this information can be difficult. It can be hard to find. We have to really think about what is it that we're trying to prognosticate about? Is it, or what is it, their life expectancy? Is it, how they're going to do in a particular condition? We need to take into consideration where they live, their function, their treatment plan. And so there is quite a lot that goes into that. And one method that I found that's very clinically useful is this e-prognosis tool. So this was again put out by UCSF. I think it's highly utilized. And if you haven't looked at it, please do take a moment, and on your web browser, you can type in eprognosis.ucsf.edu and take a look, and you'll find that there are calculators, is information about cancer screening, primarily breast and colon, and communication tips as well. So when you go onto their website, it will help you to delineate first and foremost by where your patient is located. So it's going to do some of the work that, searching for an index, if you had to search for these indices by yourself, it's going to do some of that work for you. So if your patient is living at home, nursing home, hospice, or in the hospital, it helps to guide that for you initially. It does ask if your patient's in the United States, and we kind of looked at why that might be important. And then it talks about what time frame best fits the clinical issue at hand. So if this is something chronic or new, and the age of your patient. And then as an example, it goes through and it uses an index and it will ask you to complete the questions, and it is translated into a few different languages. So we'll ask you for your age, the sex, the BMI, general health status, and then whether they have chronic conditions that would impact life expectancy and overall outcome. So conditions like chronic lung disease, emphysema, bronchitis, congestive heart failure, diabetes, high blood sugar, their functional capacity. So can they walk a quarter mile? If they were ever smokers, if they've been hospitalized, any physical, mental, or emotional issues, if they require help in handling business, shopping, getting around. So these are activities of daily living, instrumental activities of daily living, cognitive issues, and issues with bathing or showering. It asks you a few more questions. Do they have issues with pushing or pulling large objects like a living room chair? And then it will give you a score and for the overall mortality. Okay, so this is just an example of a run through. It's pretty quick. You can do it in clinic, probably in 2 to 3 minutes, and get some very good information. So again, this is the ePrognosis tool that I encourage you all to use. So let's go back to our patient. And just as a reminder, so our patient was Ms. AJ. She was a 90-year-old female who came to our clinic with mild memory loss and hypertension. Her family had all lived between 95 and 100 years of age, and her daughter was requesting an order for a mammogram. And the question was, well, what would you do? And I think in the chat, there were a variety of answers. The majority of folks said, maybe we talk about goals of care. Mammogram probably isn't, ordering the mammogram probably, maybe isn't the right way to go. But how can this tool help us? And how can the tool help us to guide our conversation with the patient's daughter? So we plugged in her information, we plugged in her age, we went through the tool, and it gives you, once you calculate everything, it gives you a screen that looks like this, and it basically says, where does your patient fall out? And so for our patient, it actually said, screening for breast cancer is more likely to harm this person than help them. And so screening would generally not be recommended. And you can see on the little dial, in terms of where they are, is it, extreme benefit, extreme harm, or somewhere in the middle. And then it gives you more information. It parses it out. And for this individual, it showed that for of 1,000 people like her who got tested for breast cancer, 100 of them would experience harm in the first year. It told us that after 10 years, of 1,000 people like this person who got tested for breast cancer, only 1 would avoid death from the breast cancer. And after 10 years, of the 1,000 people like her, 600 people would die whether or not they got tested for breast cancer. So really some very concrete information, some concrete numbers that you can use in the discussion with your patient and family member. And then in terms of benefits and harms, I always have to remind myself, it's easy to, in my mind, it's sort of, okay, well, the mammogram is a click of a button. What could the possible harms be for a 90-year-old individual? And I think we all innately know, but it's a nice reminder to just remember that, a mammogram can be uncomfortable and cause anxiety for a lot of women. And some women who get a mammogram will experience a false alarm. So these women are told that their mammogram is abnormal, and they go for additional tests, and that might be additional scans or biopsy, which then increase anxiety and worry. But in the end, the additional tests don't show breast cancer. And if your radiology department is anything like ours, there are so many callbacks. And so many people need to go for additional ultrasound. A lot of people are getting biopsies these days. And, that does cause a lot of upset for patients and families. And a mammogram might find breast cancer that could never have caused problems or symptoms in a woman's lifetime. So, I think there has been research looking at the type of breast cancer that these older women develop, and they tend in general not to be as aggressive as those experienced by younger women. So something also to consider there. And then sometimes, there's pain and other symptoms caused by a mammogram or other tests. Certainly during the pandemic, I had a number of women not want to get their mammogram because they were worried about acquiring COVID, which in a very elderly individual might be more impactful than the results of the mammogram in terms of impacting function, quality of life, and life expectancy. So quite a few, if you really parse out the harms, there might be a few that are significant to your patient. And then the tool will also give you a estimate of life expectancy. And so for our individual, she scored between 10 and 11 points. And, given her relative, good health, her life expectancy was between 5 and 7.2 years. So you might, wonder what we did in this case. And in general, the patient, we discussed the pros and cons of having the mammogram. The patient, I don't think she necessarily really was pushing for it, but her daughter was. And actually, I think I might put Valerie George on the spot. She was the clinician that managed this case. And Val, I just wonder if you have any comments about the case and the daughter in your conversation.
Hi, yes, I saw the patient first and as a follow-up, and they did ask, the daughter did request for a mammogram. I did find it surprising with her age and her health conditions. And I did talk about life expectancy, and initially I said no. But what happened was that the daughter became upset at that decision making. Hold on one second. Linda, can you shut the door when you, okay. And so what happened is that I had to consult with Dr. Sagal because she knows Dr. Sagal. And again, she had kind of an agenda with that. And I did go over those examples of, what if we find something, will she be able to do this? There may be multiple appointments. There may be harm, of pain and things like that. But the daughter was very set on her getting a mammogram. So I think the patient may have either Dr. Sagal had to call to the daughter or came back as another visit to go over it and then have the discussion.
Yes. And the daughter, Val, if my recollection is that she was very upset. Her interpretation was that we were, denying her a medical procedure that, that, was important, that could, that if she didn't get it would be life limiting for her mother.
Yes, that's correct. She was very, that's exactly right. Mm-hmm.
And she was very upset. She really felt like, gosh, she felt almost as if we were discriminating based on age. Was the sense that I got, that, oh, she's too old, you don't want her to have this because she is she's older. And that certainly was not the case at all. And I think in her situation, Val, she ultimately got the mammogram.
She ultimately got the mammogram. We decided to go ahead and do it. Yes.
Yeah. And the daughter just really, despite the information and the education, really felt very strongly about having the mammogram, and she did have it. But I think she did not, I think that was sort of the last mammogram. We weren't going to pursue that anymore, based on age and education. And I think it took the daughter some time to really adjust to the information and the data presented. But that was our outcome for the patient.
And I believe it was normal.
It was normal. It was
Yes.
absolutely normal. Yes.
Mhm.
We do have somebody asking, is there a good site app that creates these type of diagrams? The pictures are super helpful.
Oh, absolutely. So that is the e-prognosis. All of the graphics. So this here, this graphic here, and this graphic. These are all from this website here, the e-prognosis tool out of UCSF. So I'm glad somebody found that. I think these are very helpful tools. In fact, when I use the tool and discuss with my patients and their families, I show them. I will pull it up on the computer in our exam room and show them. This is the tool. This is what we're filling out. We're filling it out together. Let's get more data to really understand, you know, what science is telling us here. What do the numbers look like? And let's educate you about this.
And we do have Camille Fitzpatrick. Hi, Camille. I'm asking, was this the first time Val saw the patient? Was this Dr. Sagel's regular patient? Looks like Val just responded via the chat. So thank you, Val.
So and I'm sorry, I can't see the chat, but I do. Hello, Camille. It's very nice to see you or hear you. I think this was a relatively new patient, Val, was it?
Yeah, I think I wrote in the chat, I don't recall, I may have seen her once, or it could have been the first one. And then I wrote, there's also a trust factor there, right? So here's a, you know, a partner working with Dr. Sagel and, you know, not familiar with me. And I'm saying, no, not to do that. And so the trust factor is, you're not my doctor, you're a PA, whatever, that didn't want to believe, or, you know, there could be some thought of that. So I understand that.
Yeah.
I have a question regarding the patients. You know, the discussion, Val and Dr. Sagel, you know, sometimes I stop and I ask my patients, okay, so if it's positive, what are you, you know, how do you see yourself with the treatment, right? Are you okay with surgery? Do you want to do chemotherapy if this turns out to be? So I kind of touch on that just to get an idea. You know, we do screen, but we have to think about the outcome and the next steps. So sometimes that helps people kind of think about, okay, what are we heading for? I don't know if this was helpful for your patient at the time.
Thank you very much, Dr. Pereira. That is an excellent comment. Absolutely. So absolutely. So we do utilize that very tool. I think it's really helpful, whether it's a mammogram or a colonoscopy, you know, even follow-up blood tests or CT scans on certain things, to really sit down with your patient and say, okay, so what next? So we find something. Like, do you want chemotherapy? Do you want to even have another scan? Or, you know, do you want to see the specialist here? Because we're really headed down this road of, you know, do you want to have 5 extra appointments? And, you know, for a lot of patients, you know, that is too burdensome, impacts their quality of life too greatly, increases anxiety significantly, and they would rather not. So that is an excellent point. So really thinking 2 steps ahead for what might be, and having that conversation, very important.
One last thing is, I just had a patient a few weeks ago who has moderate dementia and has a cancer found on a CT scan. And I went through the whole thing just as you're talking about, and the treatment, but I agreed that I would go ahead and send a consult to the oncologist. And I kind of laid everything out that I don't think that she would do well, but I want them to have their own opinion. And then I got the consult back, and they're going to go ahead and proceed with chemotherapy. So I was really surprised. But I think I also had an agenda to try to sway them that I think it would cause probably more harm. I didn't say those words, but I think it's going to be difficult for her. But I gave them the opportunity because I don't ever want to have anybody not be informed. And so it was just surprising.
Yes, I think that's so important, Val. Particularly because, we're not, we're presenting, as I'm talking through this case, it's sort of like, would you order the mammogram? Would you not order the mammogram? And, we're not here to stop anyone from getting tests that they so desire. Our goal is to really educate people on the pros and cons. And so, I think we've all experienced a patient who, has advanced dementia and, is nonverbal and has a G-tube and they're full code. And you do your very, very, very best to hope that they are not coded and traumatized in that fashion. But, it's the family or the patient's desire to so have that order be in place. So really our job is to educate and advocate for the patient. But at the end of the day, people do have other choices.
We do have Angela said quality of life with that chemo choice will definitely be impacted. And then we had Mitch mentioning, I expect there are cultural variations or sensitivities to consider in the conversation.
Absolutely. 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 I think there are so many cultural aspects. I have a patient right now that I'm peripherally managing who's in the hospital with a very poor prognosis, and family has opted to trach and insert and have a peg placed due to some cultural beliefs. And I respect that, and I'm supportive of their decision making. Any other questions or thoughts about having these conversations with patients and families? Has anyone experienced a demanding family really, or how have these conversations gone for you? Oh, I think Mitch, did you have a question or comment?
Not a question, but you just in response to your ask, I just sort of reflecting. So I've worked in emergency medicine for many years, and sometimes I have these conflicts between patients and families, and especially when language is not their first, or English is not their first language. And so you end up in this sort of situation where you have to decide like who's going to rule the decision making in these conversations. And I always have to default to the patient. And so, I can say, look at, the patient is the person who has the capacity to make these choices. And the best way I can approach it is to speak to the patient and say, hey, I'm going to be doing these tests. Do you want to know why? Do you want to understand what the risks and benefits are? And or do you want me to defer this conversation to your family? And sometimes they say, yeah, just whatever my family decides is fine. And other people say no. This has been most evident where patients have sought a second opinion. But that's my only comment about your question.
Well, thank you, Mitch. Absolutely. I think patients' wishes and decisions first and foremost. Absolutely. We do run into, I think the difficulty is when the patient is unable to decide for themselves, if they are unable to communicate or did not have something in writing for themselves. The most extreme example I've seen is a woman who had breast cancer and deferred all decision making to her husband and her brother. And to the point where she did not want to even go to the medical appointments. And she just, she said, let you guys just go handle this for me. I don't want to be involved. And there was a cultural aspect to this, but I had never seen anything. It was a great learning moment for me in terms of, how to approach her and her relatives.
Like Jacqueline has a question.
Yes.
It's actually more a comment. And it's hard to not make these kind of comments just from experiences I've had. So, you know, when you have these conversations, if you're having them with the patient and the family is not there, make sure it is well documented, because, you know, you can really get burned, sued, if you have a patient that you've had this conversation, the patient's been very, you know, has made certain decisions, and then something catastrophic happens and the family sues you. And unfortunately, I've, you know, experienced that. So just, we always have to be so careful that we chart these conversations. So.
Absolutely. Wonderful point. Very important point. And I think it starts really too, you know, this is a primary care patient and we start to have goals of care conversations, or we start to ask people to bring in advanced directives or prepare advanced directives. We absolutely encourage them to have these conversations with their families first and foremost, and that their decision makers should be aware of what their, you know, what these documents include. It shouldn't be a surprise when the decision maker is faced with, you know, they shouldn't be seeing these documents for the first time when there's something very catastrophic happening. But absolutely, documentation is incredibly important. And in situation, I do have, and it's interesting that you bring this up, I have two women right now who are in their 90s, and they both have very large breast masses. I mean, on the order of 3 to 5 centimeters, they're palpable. You can see them visually. There's no tissue necrosis, like it's not fungating, but they're definitely there. And these women do come to the appointments alone. And they've opted to not have anything done. So they don't want to have even an ultrasound to see what this mass could possibly be. And I have encouraged them to bring in their decision maker to the appointment, to our subsequent appointment, for discussion if they are comfortable. So I will invite family or the surrogate decision maker or someone to be present and have an opportunity to ask these questions, so there is no ambiguity about what we're talking about. Thank you. Other questions or comments?
Somebody is asking, in the case of a mammogram, is there any legal repercussion if you follow patient wish regardless of statistics?
One way, whether to do or not do. I think if you document, I think to Jacqueline's point, you know, if your patient has decision-making ability and you document that they do or do not want a mammogram, you know, you can't force someone into the screening, to the test, right? So we follow the patient's we follow the patient's request, or we advise, we document. I don't know if that answers your question.
And we have somebody asking, is the medical team's role only to educate, to give options, or is it to give recommendations or even say no, such as giving antibiotics to a clear viral URI and the family is asking for antibiotics anyway?
That's a great question. So, you know, and I think that goes to your philosophy of clinicianship, if that's a word, or physicianhood, or, you know, whatever the term might be. And there are probably varying degrees of that depending on the clinical situation. So personally, you know, my first and foremost role is to educate and advocate for my patient. I can't force them to do anything that they don't want to do or they don't believe in, despite science, data, you know, the whole 9 yards. In terms of refusal for treatment, if it's something like a mammogram, I don't generally refuse that. But in the course of antibiotics or narcotics is another one where people want narcotics, and I don't necessarily think they need it. I generally will negotiate a plan, so that if I think something's viral and they don't really need a Z-Pak or whatever antibiotic that they're looking for, or a UTI, we generally will go through all the data. We'll talk about why we're not doing this, what the harms are. We actually, Valerie and I are dealing with another patient who has pretty much exhausted all antibiotic options, including IV and IM for urinary tract infections. And we really present the pros and cons. And we tell the patient that we'll follow them very closely, on a daily basis. We have our nurses work with them. But if a medication is not advocated because it would potentially do harm to prescribe, we're probably more strict and we'll say no. I don't know, Dr. Pereira-Val, if you have any thoughts on that.
I agree, Dr. Sehgal. I think if it's a viral infection, giving an antibiotic is causing more harm. So definitely, yeah. I mean, I would tell them, sometimes if the cough or it persists longer, I will reassess, but I will strongly recommend to do symptomatic management, and then we can always reassess if things don't improve. So.
I agree. I'll just leave it at that. Thank you.
Other comments or questions?
Looks like Eric, just to answer your question, yes, we will share the slides with you, and the recording does come out in the next day or two. So you will receive those via email as well. If you are registered, you will receive them. Does anybody have any questions for our hub team regarding this topic? Thank you so much, Dr. Sehgal. It was a very wonderful discussion regarding this topic, and we will definitely share slides with everyone. As you all can see, just some quick closing and reminders. We do have the CME form for you to fill out. You can just scan this via your phone right now if you want, and it will just bring up a quick survey. Just fill out your information. And then we do have an evaluation. We love your comments, and if you are looking for a specific topic you want us to present on, please, put that in the session evaluation as well. And then we do have quite a lot of upcoming sessions taking place over, every Wednesday and Friday. Our next one is coming up on the 27th on non-pharmacologic management of behaviors, followed by high-risk medications that can contribute to cognitive impairment. And then February will be mobility assessment and treatment strategies, and then driving and dementia on February 10th. And then we do have office hours as well. So if you do have a patient case you'd like to discuss or questions for a provider, we do offer office hours as well. And those take place every Friday, some Fridays from 12 to 1. So this is our upcoming schedule, and you will likely receive reminders about this via email as well. And again, I just have a question, how to claim CME. Just make sure you fill out that CME form that is on this slide right now. And you will receive the link, via email as well. So just make sure you fill out that form. It should be coming in the next few minutes after this session. Does anybody have any last minute questions before we end the session today?
I just wanted to say thank you to everyone for this really lively conversation. Your questions and comments were very much appreciated. Thank you very much.
Thank you. Thank you.
You all so much. And thank you for joining us from all over the US and also outside of the US. So thank you all so much, and have a good evening or afternoon wherever you all are. Thank you. See you next week.